Good morning, consultants, senior registrars, and medical officers. Today we'll be having a case presentation titled Health Education and Adherence Counseling in an Elderly Hypertensive with Poor Blood Pressure Control. Name KO, age 64 years, sex male, religion Christianity, address Asokoro, Abuja, tribe Ishan, marital status divorced, placing general outpatient department, hospital number 276326. Occupation businessman. Date scene 26 March 2025. Follow up date 28 March 2025. Presenting complaints. Headache of 5 days duration. KO was in seemingly good health until 5 days prior to presentation when he developed headache, which was sudden in onset, frontal, not radiating, severe, as it was graded as 9 over 10, sharp, intermittent, worse in the morning, relief temporary at rest, with no known aggravating factor. There was associated generalized body weakness that worsened at the peak of headaches. There was no associated fever, vomiting, dizziness, altered sleep pattern, visual disturbances, neck stiffness, or extreme sensitivity to light or sound. There was no history of fall or trauma. This was the first episode of this complaint. With worsening complaint, with worsening complaint of headache, he called his younger sister, who took him to a pharmacy where blood pressure check was 190 over 20 millimeters of mercury and random blood sugar 2.5 millimole per liter. He was given antihypertensive and intravenous fluids, for which the body weakness resolved, but the headache persisted, hence his visit for expert management. KO believes his blood pressure became labile after his children stopped taking his calls. He expressed fear about developing a stroke and dying of loneliness. K also expects to be managed properly in order to return to his businesses and daily activities. Review of systems. There was poor appetite, low mood, undue sadness, and loss of previously exciting activities. There were no seizures, loss of consciousness, cough, slurring of speech, difficulty in breathing, chest pain, increased or reduced urinary volume, numbness or burning of the hands and feet, diarrhea, constipation, or suicidal attempts. Past medical and surgical history. KO was a known hypertensive diagnosed 27 years ago with initial drug adherence, but due to family feud, had become non-adherent to medications in the last 10 years. He had no blood transfusion or surgery prior to his hospital visit. He was not a known diabetic, asthmatic, epileptic, or sickle cell disease patient. Drug history. He was on 10 milligram each of amlodipine and lisinopril and 75 milligram of clopidogrel, which he took anytime he remembered. He was allergic to sulfur-containing drugs by skin rash, body itching, and malaise. Family and social history. Kale had married 27 years ago in a monogamous family setting with 4 children: 35-year-old male engineer, 33-year-old male architect, 30-year-old male economist, and 27-year-old female medical doctor. They all reside and work in America. He had been divorced for 10 years, and his last family visit was 8 years ago. KO's family APGAR of 0 over 10 denotes a severely dysfunctional family, and he is of the empty nest family stage. He owned and managed chains of businesses within and outside his state of residence. His monthly income was in millions. He lived in a 4-bedroom duplex with a housekeeper and a chef. Their method of sewage disposal was water system, and they drank bottled water. He took 2 bottles of beer every day, about 40 units per week, and 3 sticks of cigar daily in the last 3 years. Prior to this time, he drank alcohol sparingly, but began taking 2 bottles a day about a year ago as a coping mechanism for his mental stress. KO knows that he shouldn't be drinking and feels bad about it. However, he has not felt the need to stop. No one criticizes his alcohol consumption as he drinks only at home. He was a Christian of the Catholic denomination who last attended Mass 6 years ago as he was tired of being asked of his ex-wife and children. He believes in God but feels God should not be involved as it is a family matter that he should be able to handle. General physical examination revealed an unkempt and sad-looking man. He was afebrile, acyanosis, enycteric, and not pale. There was no peripheral lymphadenopathy and no pedal edema. His height was 1.7 meters, weight was 74.4 kilograms, and body mass index was 25.74 kilogram per meter square, which made him overweight. Central nervous system showed he was conscious and alert, oriented in time, place, and person. There was no sign of any neurologic deficit. Cardiovascular system showed a pulse rate of 67 beats per minute that was regular in rhythm, normal in volume, and synchronous with the contralateral pulses. His blood pressure was 170 over 100 millimeter of mercury. The jugular venous pulse pressure was not raised. The precordium was normal active and the apex beat was at the fifth left intercostal space, mid-clavicular line. Only the first and second heart sounds were heard. Respiratory system revealed a respiratory rate of 17 cycles per minute with oxygen saturation of 98%. His trachea was central. There was equal chest expansion and percussion notes were resonant in all lung zones. The breath sounds were vesicular. Abdominal examination revealed a full abdomen that moved with respiration. There was no scar or scarification marks and no area of tenderness. The liver and spleen were not palpable. The kidneys were not balloted. Percussion notes was tympanitic and the bowel sounds were present and normal active. KO declined a digital rectal examination. A provisional diagnosis of poorly controlled hypertension secondary to poor drug adherence was made. Differential diagnosis, substance abuse, alcohol and nicotine. Persistent depressive disorder, according to Diagnostic Statistical Method 5. Psychosocial concern, family dysfunction, overweight, substance abuse, and divorcee. Management. The diagnosis and line of management were explained to the patient and with his consent to his younger sister. And the following investigations were requested: urinalysis, full blood count, fasting blood sugar, fasting lipid profile, serum electrolyte urine and creatinine, liver function test, glycated hemoglobin, chest x-ray, and electrocardiogram. His idea on the likely cause of uncontrolled blood pressure was addressed, and his fear regarding loneliness and death was allayed. The option of bringing in his housekeeper, stepbrothers, and ex-wife was suggested to the patient. He accepted and gave verbal consent to it. The plan was to meet with his housekeeper, brothers, and ex-wife, counsel on lifestyle modification and dietary approaches to stop hypertension, give antihypertensive, counsel on drug adherence, complications of hypertension, follow-up and routine checkup, and refer for behavioral physician's review. He was educated on the need for lifestyle adjustments, which would involve dietary modification. This required that KO focuses on nutrient-rich foods that are naturally low in sodium and high in potassium, calcium, magnesium, fiber, and protein. He was advised to increase his fruit and vegetable intake, choose fresh food over processed foods, drink water instead of sugary drinks, and read labels to watch for hidden sodium content. Other lifestyle changes recommended were cessation of alcohol and tobacco intake, regular exercise such as brisk walking for not less than 30 minutes a day and at least 5 days a week. KO said he was not ready to stop alcohol, which puts him in the pre-contemplation stage. Tablet hydrochlorothiazide 25 mg daily was added to his medication, which he was advised to take immediately. He was given a 2-day follow-up visit. First follow-up visit, he was accompanied by his sister and housekeeper. His housekeeper was asked if he knew his master's illness and his beliefs concerning the cause of his illness. He admitted knowing his master's illness was psychological and he believed it was due to being abandoned by his immediate family. He had tried reassuring him that everything would be fine, but he would rather reject his meals and drink to stupor. He said that his master called him the previous night with excitement and said that a doctor asked to see him. He was happy that for the first time in many years, his master was joyful. Hence, he was happy to accompany him to the hospital when he was told that the doctor wanted to see him. KO had no fresh complaints and was adherent of medication and was happy that the doctor had explained the cause of his illness without blaming him. He looked neat and well groomed, headache had resolved, and his appetite was good. The result of investigations done were HbA1c showed 5.2%, fasting blood sugar of 5.7 millimole per liter, back cell volume of 36%, full blood count and differential were normal. The electrolytes and creatinine showed urea of 10.4 millimole per liter, creatinine of 207 millimole per liter, potassium of 3.9 millimole per liter, sodium of 146 millimole per liter. Urinalysis showed protein of 2 pluses. Lipid profile was normal. His electrocardiograph strip and chest x-ray were normal. The definitive diagnosis made was hypertensive nephropathy secondary to poorly controlled hypertension. He was cancelled on the diagnosis and referred to see the nephrologist for expert care. KO presented later in the day for the nephrologist appointment. Lisinopril was discontinued and replaced with tablet elmisatan 40 mg daily. He was also given capsule Astifa 300 mg daily for 1 month. A 1 month follow-up was given him. He declined visiting the behavioral physician as he thinks she would have nothing to offer him. KO has since then been checked upon through calls. He promised to reach out to his ex-wife's best friend, who might grant him access to his children and subsequently help reunite his family. In summary, a 64-year-old divorcee, non-hypertensive with poor drug adherence, who also abused alcohol and nicotine, who presented with sudden onset headache of 5 days duration. He was from a severely dysfunctional family, which contributed to his lifestyle and poor drug adherence. His illness affected his business and general well-being. His blood pressure was successfully managed with adequate counseling and appropriate medications. Discussion. As observed in KO, hypertension is a medical condition in which the blood vessels have persistently raised pressure, increasing the pumping function of the heart and leading to hardening of the vessels. Normal adult blood pressure is defined as a systolic blood pressure of 120 mm of mercury and a diastolic blood pressure of 80 mm of mercury. Hypertension is defined as a systolic blood pressure equal to or above 140 mm of mercury and a diastolic blood pressure equal to or above 90 mm of mercury. Normal levels of both systolic and diastolic blood pressure are particularly important for the efficient function of vital organs such as the heart, brain, and kidney, and for overall health and well-being. Hypertension is classified into optimal, where blood pressure is less than 120 over 80 mm of mercury, normal, where blood pressure is less than 130 over 90 mm of mercury, mild blood pressure of 140 to 159 over 90 to 99 millimeters of mercury, moderate blood pressure of 160 to 179 over 100 to 109 millimeters of mercury as seen in the index patients, and severe blood pressure of greater than 180 over 110 millimeters of mercury. Isolated systolic hypertension grade 1 is a blood pressure of 140 over 159 over less than 90 millimeters of mercury, and grade 2 blood pressure greater than 160 over less than 90 millimeters of mercury. Hypertension can also be classified based on end organ damage into hypertensive emergency with blood pressure of greater than or equal to 180 over 120 millimeters of mercury with end organ damage, and hypertensive urgency with blood pressure of greater than or equal to 180 over 120 millimeters of mercury without end organ damage. Malignant hypertension is hypertensive emergency with papillary edema, while accelerated hypertension is a sudden and significant rise in blood pressure over baseline levels with retinopathy but no papillary edema. Hypertension is one of the major causes of premature deaths worldwide, killing over 8 million people every year. It is often asymptomatic, hence referred to as silent killer. Over 1 billion people live with high blood pressure. Prevalence increases with age, obesity, and sedentary lifestyle. Males have a slightly higher prevalence of hypertension than females in almost all countries. KO was male who lived a sedentary lifestyle. Aging populations and rapid urbanizations are reported as major contributors to the increased prevalence of hypertension in urban areas. Many people with high blood pressure in Africa remain undiagnosed and therefore miss out on treatment that could significantly reduce their risk of death and disability from heart disease and stroke. Approximately 30% of adults in the region have never had their blood pressure checked. Among those diagnosed with high blood pressure, 35% do not receive essential treatments. The pathophysiology of hypertension arises from complex interactions among genetic, environmental, and physical factors. The primary mechanisms include increased sympathetic nervous system activity, renin-angiotensin-aldosterone system dysregulation, endothelial dysfunction, renal contributions, and genetic and environmental factors. As seen in KO, family dysfunction has been documented as a modifiable risk factor for developing hypertension due to chronic stress, poor coping mechanisms, emotional and mental issues, and lack of support. Other modifiable risk factors are smoking, alcohol, physical inactivity, and stress, which were all found in the index patients. Non-modifiable risk factors for hypertension includes age, genetics, and ethnicity. Diagnosis of hypertension is primarily made through blood pressure measurements. If average readings on two or more separate visits are elevated with investigations, patients should hereby be started on antihypertensives. As seen in KO, management of hypertension involves the following: patient-centered care. Here, the patient beliefs, understanding, and fears of the disease are explored and addressed. Barriers such as drug adherences, finances, and social stressors are identified. Holistic management, which includes lifestyle modification, such as dietary approaches to reduce hypertension, diet, reduce salt, exercise, and alcohol moderation. Use of antihypertensive in a stepwise approach per guidelines. Psychosocial support, which addresses the family dynamics, and then refer for counseling. Team-based care, nurse educators, dietitians, and social workers. KO developed nephropathy due to uncontrolled hypertension. Other complications of uncontrolled hypertension are cardiovascular, myocardial infarction, left ventricular failure, renal, chronic kidney disease, neurological, stroke, transient ischemic attack, and ophthalmic hypertensive retinopathy. Just as the index patient was cancelled on DASH diets, lifestyle modification and cessation of alcohol and smoking, hypertension can be prevented by maintaining a healthy weight, physical activity, managing stress, regular monitoring of blood pressure, managing and controlling other health conditions. The role of the family physician in the management of hypertension is long-term relationship for continuity, promote shared decision making, identify and manage psychosocial contributors, screen and manage comorbidities like diabetes, dyslipidemia, depression, and educate the family to create a supportive home environment. Lessons learned. Hypertension is more than just numbers. In the context of family dysfunction, poor control often reflects deeper psychological and systemic challenges. As family physicians, we are uniquely positioned to bridge the gap between clinical care and the society reality of our patients. Thank you. Okay. References. Raquel. Okay.